I'm Sandro Galea. I have the privilege of serving as Dean of School of Public Health at WashU. Welcome to Public Health Ideas. These are conversations that aim to highlight work that's relevant to public health from faculty across Washington University. Today, I have the privilege of speaking with Professor Karen Joynt Maddox. Dr. Joynt Maddox is Associate Professor of Medicine, Associate Professor at the Washington University Brown School of Social Work, and Co-Director of the Center for Advanced Health Services Policy and Economics Research. Today, we're going to be discussing her recent paper in the journal Circulation called Forecasting the Burden of Cardiovascular Disease and Stroke in the United States through 2050, Prevalence of Risk Factors and Disease. And this is a presidential advisory from the American Heart Association. I'm very much looking forward to the conversation and to learning from Professor Joynt Maddox. Karen, thanks for being here.
Thank you for having me.
Tell us a little bit about where this work came from.
Sure. So as you know, cardiovascular disease remains the #1 killer in the U.S. and actually globally. And the American Heart Association, which is a major national organization that focuses on cardiovascular disease and public health and research, is turning 100 this year. So we thought it was a pretty good time to take stock. Where are we on cardiovascular disease? And not just take stock of where we are now, but think a little bit about where we're going to try to see, can we be strategic? Can we be thoughtful? Can we sort of collectively come together at this moment to say, what's our next 100 years look like? Organizationally, but societally, really, and what's our plan for cardiovascular disease?
Tell us from a big picture perspective, what's the state of cardiovascular disease in the U.S. today?
Yeah, so in a word, or 2 words, I guess, not good. We have about a 10-11% prevalence of cardiovascular disease or stroke in the U.S. right now. And driven by a series of very prevalent cardiovascular risk factors. So about half of U.S. adults have hypertension, about 40% are obese, about 16% have diabetes. And when you think about the health behaviors, so things like adequate sleep, healthy diet, exercise, we really don't do as well as we should. So I'd say we're at a point in U.S. history where we have more cardiovascular disease than we ever have, and an important time to think about where we're headed.
So tell me about where we're headed. Tell me about the projections at the heart of this paper.
Yeah, so the most important thing driving the increase in cardiovascular disease is actually going to be demography, which is sort of a dry and boring topic that turns out to be incredibly important right now. So the population is aging, and the demographics of the U.S. are going to change in ways that we haven't previously seen. So as the baby boomers sort of age into older adulthood, we see all of the diseases of aging, of which cardiovascular disease is obviously a major one, really going to increase. We also know there's important demographic changes in terms of race and ethnicity. And given that due to inequities in our health systems, in our history here in the US, we have a higher burden of disease in people who are Black, Hispanic, or Native American. We know that as those groups, as well as groups that identify with many races, grow, that we're likely to see growth and prevalence there as well. So even before doing any modeling, we had an idea that just based purely on demographic changes, we were going to be facing a shift in cardiovascular disease. And the goal of this project was to couple that with what we understand about trends in the actual disease burden itself.
So what did the modeling show?
So we found that cardiovascular disease is likely to grow quite a bit by 2050. So we project that the prevalence of cardiovascular disease will go from 11% to 15%, which is, tens of millions of adults, 40 million adults, and that the burden of cardiovascular disease or hypertension is going to be close to 200 million adults. So hypertension we project will grow to 60%, obesity to 60%, which is the most rapidly growing risk factor. Also projecting an increase in diabetes from about 16% to about 1 in 4 adults.
Tell me about health gaps. This is not going to be happening across all groups. There are going to be some groups with more, some with less. Tell us a little bit about that.
Yeah, so the groups in which we see the highest prevalence at baseline is also where we're seeing the biggest growth. So in the U.S., Asian American and Hispanic American groups are growing the most rapidly, and so we see the biggest demographic shifts in those groups. Within the African American community, you see the highest prevalence, particularly of hypertension, and so we see the biggest growth in that group in terms of sort of its effect on the cardiovascular outcome. So we see no indication that the inequities that we see now are headed in the right direction, and I think, in fact, have reason to believe that's an area we really need to double down.
Are we anticipating the inequities will grow as a proportion or stay roughly the same?
That's a good question. I don't know that we know. A lot of the historical data actually doesn't disaggregate by race and ethnicity well enough for us to be able to do terribly good modeling, but to the best we can tell, we suspect that those will grow. One reason we think that they'll grow is because the disparities are greatest in young adults and in children. So we know that places where we see the greatest racial and ethnic differences, and actually rural, urban differences, not from this study, but from other work that we've done, and the greatest differences by poverty are starting to emerge in widening gaps in that sort of older child, younger adult area. And if you project those forward, which we didn't formally do in this paper, I think we have every reason to believe that that's going to be a major issue.
One interesting finding, sub-finding, which I thought was certainly unexpected for me, was the drop in hypercholesterolemia, so which has been observed in other places. Tell us a little bit about that and what's driving that and the implications of that.
Yeah, it's actually a fascinating story, and I'll add one to that, which is the drop in smoking. Yeah. So two places that we've pushed really hard as a public health community and as a cardiovascular community have been on fat and smoking, right? So dietary cholesterol, dietary fat is a pretty easy message to send and was really aggressively sent. And we saw shifts in our sort of the makeup of food towards a lower fat, higher sugar diet. And we also saw decreases in smoking. Now, both of those are good, but they have been offset by massive increases in obesity. Now, that wouldn't make great sense if fat were what drove obesity, which sort of makes sense, right? We think of fat and think they must be the same thing, and they're really not. And it turns out that the more we understand about sort of the underlying biology of all this, that inflammation is really a huge driver of poor outcomes, and that's really driven by sugar. And so the increase in sugar and hyper-processed foods and all those sorts of things in our sort of, food ecosystem has more than made up for that pretty impressive improvement, actually, in cholesterol levels and the drop in smoking by pushing us back in the other direction.
So if we've succeeded, perhaps, in having less fat intake and lower rates of smoking, because we've pushed on them as a community, cardiovascular community, public health community broadly, is there hope of succeeding in changing some of this other trajectory you're talking about?
I hope so. That's certainly the goal, and I think as we think about what to do about it, you can think sort of from the micro all the way out to the macro, and that's what's been done in previous, public health interventions as well. We've done quite well as a clinical community in coming up with all sorts of fancy tools to try to treat disease. So survival rates for heart attack are better than they've ever been. Survival rates for stroke are better than they've ever been. But the number of heart attacks and the number of strokes is going in the wrong direction. So you'd think if we take that amount of energy and innovation and shift toward population and public health thinking, we really ought to be able to make a difference. And we even have examples from smoking and cholesterol of how we might do that.
Tell us a little bit about the Healthy 8 and American Health Association and how we might focus what we do over the next 25 years.
So Life's Essential 8 are 4 health behaviors and 4 health conditions, really. So the conditions are high cholesterol, high blood sugar, high body weight, and high blood pressure. So we think about those as being sort of clinical conditions to treat. And then the health behaviors are sleep, diet, physical activity, and smoking. And so collectively, those are Life's Essential 8. Sleep is the sort of new kid on the block. It's one we have the least data historically about, but I think has really emerged as an important risk factor.
On balance, how hopeful are you that we're going to be able to make a dent in the next 25 years and essentially get to a better place than what your projections suggest?
I'm actually pretty hopeful. I think I have felt a palpable shift collectively towards public and population health. I think people are sort of recognizing more and more that it's not just about treating the heart attacks and the strokes and the cancer, but that we're collectively getting quite unhealthy. I mean, the projections for some of these groups, particularly in Black adults and in current sort of middle-aged adults, could push us to nearly 100% hypertension and obesity if these trends continue, right? We just can't let that happen. And I think we have a lot of tools at our disposal that maybe we didn't have before. I think we have more awareness around public health. I think we have more concept that we can work from sort of micro to macro public health. We can work in the community and use implementation science to figure out how to do things and not just what to do. We can work at the policy level and work on insurance coverage and work on access and work on poverty and social risk and understand how those are correlated. So, at any moment in time, the political will and the complexities there will, obviously influence how we think about things. But I do think that we have much more of a collective appreciation for public health right now.
I do appreciate that hopefulness. Thank you for the work you do. Thank you for writing this paper. And thank you for joining us.
Thank you.